Psychosis 101, Understanding Psychosis. I want you to be thinking about what kinds of questions you have about psychosis. The overview for today's work, we're going to talk about what is psychosis? What are the symptoms? What is this diagnosis? What do these symptoms look like over time? Also, what causes psychosis? We'll go through the vulnerability stress model. We will then also talk about how to treat psychosis. What is early intervention? What are protective factors? And what's all this about evidence-based treatment? Okay, so first, what is psychosis? Okay, so today we're gonna talk a little bit about these different categories of symptoms. So when we say psychotic symptoms, what do we mean? We're talking about these positive symptoms, negative symptoms, and cognitive symptoms. And so we'll dive a little bit deeper into each of these categories. Okay, so what are positive symptoms? Exaggerations or things that are added to the normal human experience. So think like thoughts or sensory experiences that aren't tied to reality, are held with conviction that do not change even when faced with proof they are false. And you can sometimes think of these as your mind playing tricks on you. Importantly, these experiences really negatively impact your everyday functioning. And then the three types of positive symptoms that we'll go through, some that you might have heard of, hallucinations. This can impact any of your sensory systems. So hearing, seeing, smelling, tasting, or feeling things that are not there. And the most common type of hallucination is hearing voices. Next up, we have delusions or unusual beliefs or fixed false beliefs or thoughts. And this can include paranoia or extreme suspiciousness, delusions of reference or things in someone's environment that's having a particular or unusual significance to them. So some people may explain this like feeling like a song where the radio has a message that's directed just to you. Grandiosity is another area, feeling like you have inflated special gifts or talents or power, maybe thinking you're particularly famous or chosen by God for a special role. And particularly here, that does not fit within the typical cultural belief set. Maybe also feeling like your thoughts are heard by others. You can read others' minds or you can predict the future. So just a couple of examples of different delusions. And then thought disorder. This can include things like disorganized communication. Others have a difficult time maybe understanding what you're saying because you may lose your train of thought, go off track easily, or the words you're trying to communicate just aren't really coming out. And so depending on if you have a diagnosis of full threshold psychosis, or if you were told that maybe you just have risk for psychosis, which is a little bit different that we'll talk about in a little bit, you might experience these positive symptoms more or less intensely or frequently, or hold on to them more strongly. And they may be accompanied with more or less distress or impact on your day-to-day life. Okay. Next up, what are negative symptoms? So again, eliciting some ideas from the crowd. What does this mean? Okay. So whereas positive symptoms are exaggerations of the normal human experience, negative symptoms involve the loss or withdrawal of qualities that make us emotionally connected and motivated human beings. So this can include anhedonia, a loss of interest or pleasure in activities. For example, this might look like spending more time alone because you don't get enjoyment out of your social interactions or your previously preferred hobbies. Avolition is this lack of motivation for goal-directed behavior. It's not laziness, it's more about having a harder time getting normal activities done or losing motivation more quickly. You might notice this if a loved one provides lots of prompts for you while trying to do these activities. So like working on chores, completing daily hygiene routine, or working on school or work activities. Flat affect is another area. This looks like reduced expression of emotion through your face, your body, and your voice. So this can appear that you're unemotional or lacking modulation or inflection in your voice or gestures, maybe lacking a little spontaneity and initiative in conversations. And then last up, poverty of speech, just one other area that will give it as an example. This is reduced verbal kind of output, speaking less often. Maybe someone answers things with one-word answers. They don't really elaborate on the responses. And this can be something related to motivation. This could be something, maybe someone's preoccupied by other symptoms, or there might be many other reasons that this is happening. Okay. The last category to quickly go through is cognitive symptoms, which you can think of as impairments in how your brain works and processes information. And this includes difficulties with attention, sustaining focus, switching concentration between multiple things, maybe how you learn and retain new information, whether it's presented visually or verbally or auditorily, might impact different types of memory. So maybe you have difficulty holding things in your mind or losing that information right away. And this is called working memory. Or you might have difficulty recalling information after a longer period of time has gone by. And then also problem solving and reasoning. And this can include defining what a problem is, generating solutions, examining those pros and cons, and then implementing and evaluating how things go. And so impulsivity can sometimes get in the way of some of these things. Many of these areas are impacted through the prefrontal area of the brain. So if you want to think this area right here, and often you can think of this as like the orchestra conductor of your brain, which tells other areas how to work. And so it's a really important area that is very deeply involved in psychosis. And we'll get a little bit more into some of those details a little bit later when we talk about biological vulnerability for psychosis. Okay, so after going through those symptoms, it's important to remember that symptoms are common in our general population. So 1 in 4 individuals on psychosis screening questions in the National Comorbidity Survey say that they have psychosis symptoms. 1 in 6 say that they have these symptoms even without a diagnosis. And then 1 in 5 who go to treatment at primary care centers report 1 or more psychotic symptoms. And this is one of the most commonly auditory hallucinations. And so psychotic symptoms are quite common, and the symptoms range from more typical experiences to psychiatric symptoms that impair function. And so you can see it's a really large continuum, and that's kind of what we're going to talk about next. So I'm going to hand it over to Dr. Shapiro to chime in.
Yeah, and a nice segue, I think, for us in doing psychoeducation, it's important to remember that education itself is a really powerful intervention, one of our powerful interventions as providers here. And so there are some kind of important or key messages that we hope people take away from this presentation. This concept of a continuum is one of them. You know, education, I think, helps people build accurate knowledge, right? We're trying to combat stigma and misinformation. But also it's really important to kind of normalize, and normalizing, we hope, removes some of the distress that people have when they experience symptoms, the expectation that distress leads to more symptoms and maybe unhelpful patterns. I'm sharing this with you as presenters. But I think it's useful to say when you get to this part that we really hope this idea of a psychosis spectrum is one key thing that our families take away. So jumping back into the talk, yes, one key concept we hope you walk away with today is this notion that psychosis exists on a spectrum. And all of us, you and me included, kind of exist or fluctuate somewhere along this spectrum. Think about what might differentiate a sort of normal end of the psychosis spectrum from what we might see as more problematic end of the spectrum. So take a moment to think for yourself, right? What differentiates something that we would consider normal in the psychosis spectrum from something that seems more problematic? And as we work through this spectrum, that's kind of the route we're taking, from what is common, as Dr. Ereshefsky was saying, quite common, to what might bring somebody to our clinic. So on the normal end of the spectrum, these are things that occur perhaps without a lot of distress, that are infrequent or rare, and that don't really have a big impact. distract, they don't change your behavior, they don't impact your life or get in the way. So, some great examples are raise your hand or mentally raise your hand. If you've ever heard your cell phone ring and in fact it didn't ring, or if you're a parent, if you've ever heard your children call your name and they're not in the house or they're sleeping or there's no way they could have heard you, right? Or you wonder if your coworkers or your friends are thinking bad things about you or purposely trying to exclude you from their plans. These are really normal. We can suggest that these are sort of on the normal end of this psychosis spectrum. So taking an example, we also, for many cases, see that people don't wake up one day with full threshold psychotic symptoms. For many people, there is a sort of gradual lead up over time with things starting on the normal end of the spectrum and occurring more frequently, starting to become more confusing and then more distressing. There are certainly cases where these pop up in acute phases right away, but this is more prototypical. So to think about an example, this is an example actually from one of our colleagues. Imagine seeing a ghost. This happened to this colleague. The ghost appeared one time at night while they were trying to sleep. They thought it was a loved one who had recently passed. This was comforting to the person, wasn't a whole lot of impact, although as she tells the story, she talked to her mother about this and actually learned that her mother had similar beliefs and had some similar experiences. So this was really consistent with what was normal for her culture, normal in their family. This was a common experience, right? No distress, not a lot of impact on functioning. This was actually comforting more than it was scary. So moving along, sort of along this spectrum, we often see these things start to increase. So imagine this has happened to you, and now it's happened again, or maybe it starts to even happen weekly. Once in a while, things you're pretty easily able to pass off, but once they start to recur, right now your mind starts to try to put the pieces together and wonder what's happening. So as we move into what we call this attenuated part of the spectrum, what we think of as clinical high risk or sort of ultra high risk part of the spectrum, we're now starting to see recurrence. It's bothersome. Why is this happening? There seems to be some meaning now because it's happening more and more, but I can kind of reality test and I recognize this isn't really happening. And actually, maybe that's even where some of the distress is coming from. Like, I know this isn't possible, and yet it keeps happening. Why is this happening to me? Typically early on, it doesn't affect your behavior so much. You kind of think about it. You might check in with your head a little bit, but you can kind of keep going on your way. So using our example, this ghost has now started to come back a few times a month. This colleague wasn't really sure why. This was not so consistent with what her mom was saying, starting to wonder if maybe it's real, but that still kind of seems out of bounds. It's affecting sleep. So we're starting to see some distress pop up. Moving us along a little bit here, further through this attenuated part of the spectrum. Now it's occurring weekly, right? And again, as you have these sort of intrusive experiences, it's human nature to try to figure out what's going on. So maybe now the person is starting to put together some theories. It's starting to feel more distressing. The fact that it's recurring makes you wonder, okay, is this real? Could this really be happening? It doesn't match my beliefs, but maybe it's there. And now maybe it's starting to impact your behavior. You're looking for signs. You're trying to catch the ghost. Maybe you stay up late to try to look for signs of it. And using our example, maybe now this is a few times a week and it's not so comforting anymore, right? So the theory could be, maybe this is my dead relative trying to communicate with me. Maybe there's something special about me. I'm able to see this because there's something unique or special. I have a gift. And again, I think impacting your behavior, and you can see how this would cycle too. Less sleep, more preoccupation is going to potentially lead to more distress and more symptoms. Once we reach a point of psychosis threshold, for those of you that have done some of your SIPS training, we see that threshold as occurring when conviction hits 100%. I am now sure this is happening. I'm sure there is a ghost in the room. It's scary. I can't really be shaken out of this conviction. That's the point at which we would say this threshold is met, and we've sort of moved further along this spectrum. So using our example, perhaps now this person is starting to think, has developed the belief that the dead is communicating with her. It's really scary. This is happening while she's trying to sleep in her safe space. She might be communicating back with the ghost. And this is starting to impact work and school. It's really distracting. People can fluctuate some along this threshold, which makes some of our assessment questions a little more complicated at times. The hope is that this spectrum idea helps people feel not so different, right? And really communicates that what you do and the way you make sense is what differentiates the quote normal from the abnormal. We're trying to kind of divest people from this idea that they're losing it, right? Or some of the stigma beliefs like, right, this is illness, I'm broken, I'm crazy, right? This spectrum really helps people to feel some kinship with others. Following this point, symptoms are common. Psychosis symptoms are common. Disorders, psychotic disorders, what we would label with the DSM, for example, are less common. And it's really these points of distress and impact that differentiate a disorder from a non-disorder. So psychotic disorders, we say, are found in about 1 in 50 people, about 2% at any given time. And our average age of onset is teens and 20s. So that's for this full threshold. The spectrum often for people in a prototypical case we're seeing pop up a couple of months, even to a couple of years before people meet that threshold, looking a little bit earlier. A diagnosis, what makes this different, right? Again, we're thinking about impact, distress. A diagnosis itself is a label. It helps us communicate with other health professionals so that they might understand the terminology we're using and what somebody's experiencing. It's sort of like a syndrome. Think about it as a syndrome. It's a set of symptoms that co-occur in certain ways. And ultimately, the reason this is useful is because different syndromes lead to different treatments that might have more or less likelihood of being successful. Right? We try to do research that matches the treatments to the symptoms. These do change. This is a really nice kind of demonstration of a prototypical course of psychosis. Really key point for you as assessors is that when we see people walk through our doors, we are getting a tiny little sliver of this overall picture, right? You are getting a small window in what ultimately winds up being the life course of symptoms, right, or their experiences. And so we're doing our best to match a label and a diagnosis to this whole life course based only on one small bit of data, right? So diagnoses change, experiences change for young people. And actually, we find that for a number of folks in that clinical high-risk phase, that symptoms even remit on their own without treatment or with good identification. Okay. So this is another key point that we hope people will take away from the workshop. We've identified at this point some types of symptoms. We sort of distinguished, right, what positive and negative look like. We have talked a little bit about this spectrum idea. For you, trying to fit the right label, think about a prototype matching kind of model. Because we have this tiny little sliver at the beginning, right, we are doing some prediction based on what you have in front of you. So the idea of a prototype is the more what you have in your office in front of you looks like a prototypical case of psychosis, maybe the more your confidence jumps that that is the right label for this picture, right? The less what you have in front of you, the less it looks like the prototype, or the more other stuff is going on, the more unclear this is, right? The more muddy or unsure we are. So the prototype for us is seeing these negative symptoms. So these are in red. Looking at this figure, we have time on the horizontal axis going left to right. We are increasing over time. Yes, the vertical axis here, think about severity of symptoms. So as you move from left to right, we're going forward in time. As you go from bottom to top, we're talking about symptoms that are getting worse. So looking at red, negative symptoms in red, we typically see negative symptoms pop up first. The further away these symptoms are from the onset of psychosis, typically, the less easy it is to identify them as psychosis, if that makes sense, right? So think about a low-level negative symptoms, difficulty in school, difficulty concentrating, poor motivation, hard time getting started on things. I think all of us could think back to our adolescence and probably identify a couple of those. Right? These are the further away you get from the onset of psychosis, the more difficult it is to distinguish these early symptoms from what we are calling psychosis. So yes, in this prototype, typically we see the negative symptoms pop up first, followed by gradually increasing positive symptoms. So these are the blue line here. It is not always linear, right? There's some coming and going depending on what's going on in your life or your stressors. And then once we hit the acute phase, that is marked by this vertical line here, that point of conviction, we label this as psychosis. So for us intervening, we know that the earlier we intervene, the better people's long-term outcomes are. So our goal is to try to jump in as soon as possible. There is another period in here. It takes a while usually for people to identify psychosis. You can ask your families. It's very interesting to see the range that families guess. Yes, actually in this country, it's about a year and a half. I mean, imagine having these symptoms of psychosis for a year and a half without any support or treatment. I mean, that is a long time to sit with these scary things. So the other thing I think to demonstrate in this figure, right, beyond that, the goal of early intervention is that there is often fluctuation in symptoms over time, but also we are much better in our treatments at addressing positive symptoms than negative symptoms. We often see with treatment, or even for some people without treatment, the positive symptoms do start to tail off a little bit, while the negative symptoms often stick around. And actually, unfortunately, in our treatments also are not as great at addressing negative symptoms. Probably everybody on this call can relate to that fact. Right. Just for you to know, another key concept, right? Considering this idea of spectrum normalizing is the concept of the vulnerability stress model. The idea here is that our biological contributants, the heritable things that contribute to psychosis, interact with environmental stressors. And there are a lot on both sides to lead to really anything. This is the same model we have for all illnesses, physical illnesses too. If any of you have physical injuries, right, or health conditions, you probably relate that in moments of stress, physical stress, overuse, those conditions are much more likely to pop up or flare up. The things in your family that run in your family may have popped up for you for the first time during a period of stress. The same goes here with psychosis. So another graph, different things on the different axes here. So this time our horizontal axis is this hypothetical concept of biological vulnerability. So moving from left to right, we're imagining someone with a low level of biological vulnerability, moving along the spectrum towards the right, considering high level. And on the vertical axis, imagine this as stress. And stress is a broad concept here. We mean psychological stress, mental stress. Sometimes this is physiological stress. Imagine not sleeping for a long time. And this red line kind of going along the top, this is the presence of symptoms. Again, this really applies to anything. But thinking about psychosis, what we're saying here is that somebody with a lower level of biological vulnerability might need a higher level of stress to hit that red threshold. So for any of us, if we were to go a week without sleeping, we would probably develop symptoms of psychosis. Extreme psychological stress. Good examples of conditions that might yield psychosis due to stress. Any thoughts, Dr. Ereshefsky? Any other good examples to share with families?
Substance use is a stressor on the system. So
Yeah,
that's
good one.
repeated.
Good.
Yeah, it can be a stressor on the system and kind of bring about some type of biological vulnerability.
Great example. Yeah. Delirium, right? There's like some kind of stress on the body. Great example, right? The converse, I think, is an important concept for our clients too, that if you have a higher level of this heritable or biological vulnerability, it takes less stress for you to hit that threshold. So for our folks that we know have some family history or have experienced symptoms before, that's an indication that they have a higher biological vulnerability. They may need to be more careful than their friends about these biological stressors. This is one of our message for things like cannabis too, right? You have a higher vulnerability, you may be impacted differently. But this really does normalize again. This helps people kind of plan their response and remove this like illness model, this either or model. You're either there's something wrong with you or you're normal, which is really counterproductive for us. So biological vulnerability comes from a number of places. I think clients and families like to ask questions about this. I will say that it is not that important, I think, as you give outreach talks or psychoed talks to hone in on specifics. We do know of some genes that are involved in vulnerability. However, unfortunately, we hoped there would be a simple genetic picture, and it's actually really complicated. There are hundreds, maybe even thousands of genes, and they interact. So there's not a psychosis gene. We know about some areas of the brain that seem to be involved in psychosis that are either overactive or a little less active or talk to each other in different ways for those who experience psychosis. However, there's not a signature. We can't do a scan and find that signature by looking at pictures of your brain. So these are looking across large numbers of people. There's lots of interesting stuff here that we could save for other days about where we're finding these genes. One interesting thing here is that there are some traits that can be passed on through vulnerability genes for people who don't hit that red line. So you may see some like relatives of those with psychosis who have some similar experiences, maybe some lower level psychosis spectrum symptoms, maybe some of those symptoms in isolation without a diagnosis. So worth noting, right? Some of these traits might run in families. We touched, you probably can guess the key environmental stressors here. Some of these things have to do with development, physiological development, things that occur prenatally or during delivery. Perhaps the most tightly linked is trauma. And we think about trauma broadly defined. So like having sort of adverse environments, actual traumatic events, trauma disorders, experiences of trauma. These are environmental stressors that are sort of disruptive to our brains that can move us along that threshold. And then also daily stressors actually are important here too. So family stress, social stress, the piling up of these things is something we may want to look for. Particular stress in school or in social environments. These are adolescents often. And yeah, thanks for the suggestion of substance abuse. That's pretty key. I would say this is a key takeaway. These days, marijuana is pretty ubiquitous among young people. Many of our states, California included, have legal marijuana for recreational use. It is everywhere for young people. So I think we want to be clear that marijuana, even more, cannabis more than some other substances, is linked with psychosis. It moves people along in that graph, right? If you have a biological vulnerability, you are more sensitive to the impact of marijuana. And this is reflected in some very direct research, actually. We have longitudinal research now linking regular marijuana use earlier in life to incidence of psychosis later. Using marijuana, this was daily, this study, daily or regularly, before age 15 made people 4 times more likely to develop psychosis as an adult. It also seems linked to the THC concentration. So these days, cannabis is much more potent than it used to be. And there are lots of products there on the market that are concentrated THC. So using high potency cannabis makes you 3 times more likely. The evidence here is very clear and actually pretty alarming.
All right, I'm going to pick back up here. Thank you, Dr. Shapiro. So now that we know what psychosis is and what causes psychosis, let's dive a little bit into the question that many of you are probably anxious to hear about, which is how do we treat psychosis? And so 3 key points that we'll go over is the importance of early intervention, boosting protective factors, and the use of evidence-based treatments. So the great thing is you are all part of an early psychosis program, speaking to you all, which means you're here in the early stages of illness. And this is great because research from the past 2 decades really supports the importance of early intervention. But why? It's less invasive at this point in the illness trajectory. Behavioral interventions are sometimes sufficient, and if medications are necessary, you can start off with lower doses, and those can be effective. It can be more effective. In general, this early treatment, you might be able to move towards recovery faster. You might have more hope. There's more capacity for change. It also can lead to better outcomes. So we talked about that DUP, that duration of untreated psychosis, that 1.5 years kind of time frame. And so the longer that goes on, that's associated with more challenging recovery. And so the benefits of early intervention, can ameliorate some of that impact. Yeah, so additional areas of benefit, there's sometimes less treatment resistance, and there's lower risk of relapse at this point, reduced disruptions to work or school attendance, retention of social skills and support, sometimes decreased need for hospitalization, reduced family disruption and distress. And so, yeah, overall, you can see early intervention leads to reduced risk of unemployment, homelessness, victimization, and social isolation for people with psychosis compared to those without a psychosis diagnosis. Okay. We don't always know why some people get better, but we know some of the things that are protective factors that can bolster this recovery. And we'll go a little bit more into the concept of recovery in our next workshop. And so things that can bolster recovery include treating mood, anxiety, alongside the psychosis symptoms. So some individuals only have psychosis symptoms when they're depressed or when they're experiencing mania, for instance, or they have more anxiety or more mood symptoms when they have active psychosis symptoms. So treating depression and anxiety can have this kind of double bang for your buck effect by also helping to treat the psychosis symptoms. There are also very specific strategies to learn during therapy to target psychosis specific symptoms like hallucinations and delusions. So treating symptoms is a very important concept. We also know that maintaining physical health can be protective. As we talked about before, a major stressor on your physiological system is little sleep, but also too much sleep can be impacting. We also already talked about using substances can exacerbate or worsen psychosis symptoms. Best practices can be keeping a structured sleep schedule, structured eating schedule and exercise, and limiting or eliminating substances. We did talk about the concept of stress, but it's impossible to eliminate all stressful experiences in your life. Rather, the goal should be to reduce any unnecessary stressors and learn strategies to cope more effectively with life stressors. So like adapting educational, occupational, and family responsibilities by adding additional supports or working within someone's strengths. Additional areas that to consider are identifying effective coping skills and practicing them. This is even practicing skills even when symptoms are not present. So when you're practicing these skills, you can more effectively pull them out of your toolkit and use them when you really need them. Strengthening family support and incorporating family or support persons into someone's treatment plan can also be a really effective tool. Support persons can help build more understanding and empathy towards what their loved one is going through. It can also be useful to support individuals around problem solving, around the best ways to support individuals. And then finally, a new diagnosis can be isolating. So it's important to increase social support, not limit it at this point. This can come in many flavors depending on what's important to you. So extending the support outside of your immediate network can help spread to different types of support. So really kind of using your whole network for different purposes maybe. So the interventions we use in coordinated specialty care model, which is the type of model our clinic has, are evidence-based. And so some specific examples of interventions may be biological. So these could be medication. We talked about early intervention. You can go with this approach called start low and go slow. And so the goal is to be on the least amount of medication that can give the most effectiveness. Also, kind of a biological intervention is substance use management. We take a harm reduction approach in our treatment. So working with people who are motivated to cut down on substances, knowing it can take some time to get to abstinence. However, as we've learned, substances can interact with symptoms and worsen them. So providing a lot of education on the effects is also important. And in some clinics, they offer some types of groups that can help to work with individuals. So substance management groups or kind of risk reduction groups can be a helpful tool here. Within psychological or cognitive kind of frame, we use an approach called cognitive behavior therapy, and we provide this in individual and group therapy spaces. This approach helps individuals connect their thoughts, their feelings, their behaviors, and their body sensations, and work to disrupt these unhelpful cycles. There's also a specific approach that integrates these CBT concepts with treatment of individuals with psychosis, so called CBTP, so CBT for psychosis. There's also some effective tools that are evidence-based called cognitive remediation. These are like brain games that can strengthen some of those cognitive impacts that we talked about earlier. Skills training, this is a really effective tool. This can take place in individual settings or group settings, but especially in group settings, you can get that real world practice with others who have similar goals. Supported education and employment. This is where individuals who receive these services can get help with communicating with schools and jobs to get appropriate supports, or maybe a supported education employment specialist can help clients work toward different educational and vocational goals. And then last in this little bubble, peer and family support. You may have the opportunity to work with someone with lived experience, who either has their own history of receiving treatment for psychosis, and they can walk alongside clients in their recovery process. Or you may work with a family advocate, for instance, who is a family member of someone with psychosis or supports other family members of their clients. Best practices also indicate supporting families in other ways. Some clinics offer multifamily group as one way for ongoing learning among and between family members. And this is often in a closed group setting so that you can continue to kind of build rapport within that group. And then there's also these psychoeducation workshops. A good focus for families can be family-focused therapy. And this can be a space for families to learn more about psychosis, work on interactions, communication, and problem solving that can work toward alleviating factors that are maybe disrupting the family system. So as you're thinking about all these different treatment options that are offered in this coordinated specialty care setting, it's important to understand what it means for something to be evidence-based. So for a practice or treatment to be evidence-based, it means that it's backed by high quality, well-controlled, rigorous research experiments. In addition, it takes into account clinical expertise in the person that's delivering that treatment, as well as patient values and preferences. And it's really important to remember that treatment is not one size fits all. You should be working with your clinical team to always tailor and individualize treatment approaches based on all these factors. So really wanting to make this the most effective treatment for you. And so just lastly, a small plug, not going to go too much in detail, but you may have heard things about like dietary supplements or vitamins or special diets that some people say help psychosis. We want to caution you that that is not an evidence-based treatment. There's very limited evidence to support the use of vitamins and supplements to treat psychosis. But as we reviewed before, there are some things that are protective factors, like we talked about having a healthy, balanced diet, limiting processed foods, getting good sleep and all that. With that said, it's very important that you tell your treatment team and your prescriber about any vitamins or supplements that you or your loved ones may be taking. So there can sometimes be interactions with medication or unknown side effects, and we want to just help you proceed as thoughtfully and as possible with your treatment. So as we've gone through today, you've learned a lot about what is psychosis, what causes psychosis, and how do we treat psychosis.